Thank you.
All right, recording has begun. All right, pneumonia. Pneumonia is one of the disorders that are draining Medicare funds. So it's only fitting that Joint Commission added core measures for this disorder. And major part of the core measure is for us to identify it early, and that medications, specifically antibiotics, are administered within 4 hours of diagnosis. Okay, so that's a big core measure, because as you'll see later when we get to the bottom of this pneumonia section, one of the complications is sepsis. Okay, so let's start. What is pneumonia? Thank you for reading, Alicia.
What page are we on?
Professor, I see you, not your slide.
Okay. Why, you don't want to see me either?
No.
No, sir. That's the point of at home.
So what is
Pneumonia.
What page is this?
Sir, I'm here. Are you taking attendance?
598.
attendance?
At 9:50.
Okay, I'm gonna read. Okay, pneumonia is excess fluid in the lungs from an inflammatory process. This disease can seriously reduce gas exchange. Gas exchange is oxygen transport to the cells and carbon dioxide transport away from cells through ventilation and diffusion.
Okay, so long story short, how is this formed? How do you get it? Next paragraph, Miss Leslie.
What page are you on?
So basically it's fluid buildup on the lungs.
Well, that is the end result, but this is an infectious process, correct? So organisms, we'll talk about a few of the organisms shortly when we go to the. So are we breathing in sterile air?
No.
So is this respiratory tract sterile?
The process begins when organisms penetrate the
We'll
airway.
Are we breathing in sterile air?
No.
No.
Our respiratory tract sterile?
No.
No, we learned that last week, right? We learned about protease and how it breaks down debris that from pollutants.
Hey, babe.
Mute your mic.
Not paying attention to me. You're just on your phone.
Mute your mic.
Very nice to know. White blood cells, of course, go to the area to get off the infection. However, since
a degree for women.
So
you got that degree for women?
I got deodorant marks. Ariel, your mic is open.
Ariel, your mic. Mute yourself.
Sorry, guys.
All right, are we done with this?
Professor, I just want to know what page you're on because I can't hear anyone say what page you're on.
598.
In the textbook is 598?
598.
Okay, thank you. I'm sorry.
Okay. So when you have an inflammatory response, of course, if you remember from chapter 17, what will trigger the white blood cells is, of course, it has to be triggered first by cytokines, right? These are inflammatory cytokines that cause changes specifically in capillaries. So the capillaries become leaky, causing fluid to leak out along with larger debris, specifically albumin and other larger molecules that don't normally pass through the capillary membrane. They now leak into the alveoli. And of course, the alveoli are wrapped by these capillaries. We reviewed the anatomy of the lungs of the respiratory system last week. So that will lead to the capillary leak will of course lead to edema and then exudate. So these are now the fluids that build up and collect in and around the alveoli. Then we have pneumonia. In certain conditions, it may progress to empyema, meaning it's not just exudate that will be forming, but you'll have pus forming also in the lung. But that's not very common. So on X-ray, what does the lung normally look like? If you've seen an X-ray film?
Is it like white?
No.
I saw one today of a COVID patient. It was clear, and then like the most recent result showed a lot of fibrosis. It looked like
Appears
it
as
started becoming- it went from transparent basically to like thickened, like you could see it on the X-ray.
okay. So normal lung, a lung film would appear black. The only white stuff you see are the silhouette of the ribs, and also of course the heart, because the heart is filled with liquid, which is blood. Lungs normally fill with air, so they would appear black or almost invisible on X-ray.
Oh, okay.
When you have exudate in them, fluid building up, which is a complication of COVID-19, they form pneumonia, they now appear white. So on X-ray, you'll see scattered patches of white stuff on X-ray. So they call this increased density or sometimes infiltrates. I'm getting a little bit ahead of myself, but I'll show you those in the diagnostic test. So etiology, we have different organisms, depends really on what type of pneumonia you get. So pneumonia can be community acquired or healthcare associated. Healthcare acquired pneumonia will be further subdivided into different types. But regardless of the type of pneumonia, they are treated the same way. They appear the same way on X-ray. These are the most common organisms that can cause it. It's not only bacterial, but it could be viral pneumonia, which is what we have with COVID-19 right now. It could be fungal, could be mycoplasma, or it could be also parasitic, like helminths, for instance, or protozoans.
What about aspiration pneumonia?
That is one of the categories which will go next, which is under healthcare acquired pneumonia.
Okay.
All right, table 31-1. These are now risk factors for pneumonia. They have similarities. So community acquired pneumonia, meaning you have no risk factors, you have not been admitted in the hospital, you don't live in a nursing home, meaning you'd have no known risk factors for healthcare acquired pneumonia, meaning you've never been treated for cancer, for instance, never lived or been admitted to a healthcare facility. Okay, if you don't have those, then the doctors would consider your pneumonia as community acquired. These are the risk factors that increase your tendency to develop it. Age is the number one. We put the limit at 65. So on the exam, when you see the name older adult or elderly, that is referring to an individual 65 years or older. Questions so far?
No.
Okay.
Nothing.
Healthcare associated pneumonia, they have the same risk factor, age. However, we have different criteria now, or different risk factors. So if a patient had any of these, for instance, have a chronic lung disease, altered level of consciousness, because that will lead to an aspiration pneumonia. If you have any tube in the tracheostomy tube, or an NG tube, so a feeding tube, breathing tube, whatever. So of course, these are all things you'll find in a healthcare facility, either in a rehab facility or in the hospital or in many other institutions. And last but not least is, of course, those receiving mechanical ventilation. This typically develops after 2 days of being on a ventilator. These are the most common causative agents if you develop community-acquired pneumonia. The common flu is a frequent bad guy causing the pneumonia. Of course, that one is viral. Streptococcus also is common. And this is usually the treatment. A minimum of 5 days. We can stretch that to about 7 days. Doctors typically don't wait because of the Joint Commission core measure. Remember, I mentioned that antibiotics must be started early. The sooner you treat it, then the less likelihood it'll become the patient will become septic. The reason for this is imagine lung tissue. We've never seen lung tissue. I mean, I've never seen it because they don't sell it in the grocery. We see liver tissue being sold all the time, but my assumption is it must not taste good, or maybe it doesn't hold itself very well outside. You know, when you slaughter a cow or a pig, I guess maybe it doesn't. Maybe it disintegrates. I don't really know why it's not sold. But the closest thing to it is the liver. You've seen liver, you've felt liver, right? Tissue?
Yeah.
Yeah.
Okay, so it's why does it look red?
It's like
Yeah,
dark.
Dark brown.
Well, that's already a dead liver. But imagine if it was alive, what color would it be?
Red.
Red.
Okay, very red. So imagine lung tissue like that. What would make an organ appear very red like that?
Blood.
Large blood supply.
All right, so it's rich, it is very vascular. Imagine those 50 million alveoli are wrapped in capillary, right? So it's very vascular. So is it hard or is it easy for an organism? So for any of these organisms here, once they're inside the lung tissue, can they enter the bloodstream?
Yeah.
Very easily enter the bloodstream. So that explains why it's very high risk for sepsis. Sepsis, of course, starts from an infection. It becomes systemic. We'll discuss sepsis in chapter 37 in your 5th semester. Healthcare associated pneumonia, you have several definitions here. So if you develop or we diagnose the pneumonia after you've been in the hospital for more than 2 days, within the last 90 days, meaning even if it developed outside the hospital, but you were in the hospital for more than 48 hours, that is still considered healthcare associated pneumonia. If you live in a nursing home or assisted living, you're receiving treatment for something, let's say wound care, antibiotics, or cancer chemotherapy in the past 30 days, and then you develop pneumonia, that is still considered healthcare associated pneumonia, or seen at the hospital or receive dialysis. Others are, this one, ventilator associated pneumonia. So if you've been intubated for 2 or more days, then it's all considered healthcare associated pneumonia. Questions so far?
No.
No.
I won't test you on the treatment. See this third column on this table. I won't test you on the treatment. We will have another opportunity specifically for ventilator associated pneumonia, because the Joint Commission again instituted core measures for this, specifically for ventilator associated pneumonia, and this is part of that bundle, meaning every intubated patient must receive this bundle, okay, to prevent ventilator-associated pneumonia. This is not exclusive, meaning the list is slightly longer. This is discussed in chapter 32. Again, that would be 5th semester. So for
Oh,
series,
sorry, Professor, real quick. Going back up to that chart, we don't have to know the third column for all the rest of them, just that last one.
yes, I'm just trying to show you that pneumonia has different types.
Okay.
Yeah. So why do you think we have to diagnose the type? Because
So you can begin treatment.
with antibiotics. So what's the really big reason why we have to identify whether it's community acquired or healthcare associated?
Insurance purposes.
Exactly. So it's about money. It's about reimbursement purposes. Reimbursement drops if it becomes if it's healthcare associated pneumonia. Meaning that's why we have bundles here. For instance, this one, because it's high for a ventilated patient to develop pneumonia, so you have to take measures in order to uh, prevent it. So therefore, if you expect to be reimbursed for it, you have to show cost that you did all these, that you have documentation that you did all you can, so that maybe you'll get reimbursement. I mean, you higher reimbursement. Okay, so therefore, it's better to prevent pneumonia rather than treat it. So under health promotion, of course, we want to prevent it. We have other measures here, chart 31-1. So big thing here is vaccination. Because vaccination is in NCLEX. There are 2 vaccines out there now. The patient will be given Prevnar 13 and Prevnar PPSV 23. We'll just call them PCV 13 and PPSV 23. Okay, question on your exam will be one of the links I sent to you last week. Okay, so this is somebody mute your mic, please. Okay, it would be this one, cdc.gov vaccines. I sent the link last week. So I open the link, this is it. Now this will cover both pediatrics and adult. My course is NUR 104 Med-Surg, so I'll only focus on the adult part. So we will start from here. So the link covers all ages, but for our exam, I will only cover adults 19 through 64 years of age. And of course, because age is the #1 risk factor, there will be a separate one for those 65 years and older. I will leave the pediatric part for peds. You have Miss Professor Buckner, right?
Yeah.
Okay. So before I go with adults 19 to 64, because when you admit the patient, by the way, who do we screen for pneumonia vaccination?
Is it over
People who are
65?
older.
Okay, that is the #1. It's based on age
Mhm.
because we just learned that older adults have the high risk, right? We know 65 years and older are at risk for pneumonia. However, as you clearly see here, adults 19 to 64 is also included. And although I skipped this, look at the age group here. So is there really anyone that you do not screen for vaccination?
No.
No. All hospital admissions or whether you're in a nursing home, for instance, all admissions must be screened for whether or not they're candidates for pneumonia vaccination. But because the age starts at 65, I'll start with 65 first and come back to adults 19 through 64. So let me just scroll down slowly here and start at 65. Okay. So if you are 65, first thing you ask is, have you had a vaccination, sir or ma'am? Okay. If the answer of the patient is no, what will you give them?
A vaccination?
You give them the vaccine.
Okay, so you have two conditions here, 1 and then 2. All right.
Don't you give the PV13 first?
All right, that's correct. Okay, so let's look at the first scenario. So let's say the patient is just old. Okay, that's it. No other condition, meaning they don't have any medical condition that makes them at risk for what is this? Medical conditions, other conditions, and they've never received a 13, meaning this will be their first pneumonia vaccination. You will give meaning they've never had one before, so meaning they've never received the PCV13. So you will give the PCV13 first, and then you'll give PPSV23 1 year from then. So let's say I come in, I just got old. Okay, I reached 65, but no COPD. I'm not a smoker, etc. And I'm not immunocompromised. I have no CSF leak, no cochlear implant. All right. And I've never received the 13. So I will get the 13 first and then the 23 1 year later. So this is one rule: between a 13 and a 23, there must be 1 year between them. But this is only for a healthy older adult. Question so far?
No.
Okay. So let's say I live longer. So I got I'm 65 now. So what do I get today?
PPSV 23.
No, I've never received a 13. This will be
Then you would get the 13.
all right. So I'll get the 13 first. And then, by the way, a 13, 23, the numbers correspond to the number of strains that they protect you against, because like the flu, pneumonia has several strains. So 13, PCV13, obviously by the number, it protects you from 13 strains, and then the PPSV23 protects you from another 23 different strains, okay? So I get the 13 today. When do I get the 23?
1 year later.
Right. So March 24 next year, I will get the 23. Let's say I live longer. Okay, I reach 66. Oh no, I reach 71. Can I get another one?
It's every 5 years, so yes.
Okay, so I will get another 23. What if I live up to 76?
Well, how old were you before?
Okay.
But the dose is given every 5 years, right?
Yeah.
The booster doses are given every 5 years.
So I received my first 23 at age 66. And then you said when I turn 71, I'll get a second 23, right?
Yeah.
Yes.
Mhm.
I thought it was only with one booster.
Last dose at least 5 years.
I thought the pneumonia vaccine was standardly given every 5 years.
The 23, yeah.
Yeah. Mhm.
See, there is no subsequent dose for 13, right?
No, the 23, yes. The 23 every 5 years.
Okay, so the 13, this will be your another clue. The 13 is any person must only receive the 13 once. There's really no benefit to getting it again.